very much, Dr. Tipu. And I would be talking about the aortic stenosis, diagnosis, and beyond the diagnosis. So I'll start with, and she was practically asymptomatic, as the family says. She had a 3 to 4 by 6 ejection systolic murmur. Her ECG showed LVH. Her blood pressure was normal, 130 by 80, and her coronary angio was normal when she came to me. And you see here that यार इसका मोड चेंज कर दे. She had significant calcification of the aortic valve, good LV function. She had a bicuspid aortic valve. You can see here, annulus was measured, and there was no associated aortopathy. We measured the aortic valve area using the standard equation, LV outflow tract TVI, and the aortic valve peak velocity and gradient. And she had a severe aortic stenosis. Area came out to be 0.68, index area 0.33. Her DVI was 0.21, stroke volume index 36. So how do we deal with that? And I'll talk with during my talk how we decided to deal with her. So echo is the key to confirming the diagnosis. It looks at the severity of the aortic stenosis, the valve calcifications, wall thickness and LV function, diastolic function, strain, other valves, whether they are involved or not, and the aortic pathology. Most importantly, we have to assess these patients when blood pressure is controlled to avoid the confounding flow effects of increased afterload. And the modalities, other modalities apart from echo, what we can use is the DSE or stress imaging, CT when severity is uncertain, and CMR. And there is some emerging role of the PET. Now you see here, this is the sequence of events, how the things progress in aortic stenosis when afterload increases, myocyte cell death and fibrosis sets in, and then the symptoms occur. Now I would talk about the intricacies of the diagnosis. The most important thing is from where to evaluate the aortic valve severity. And the important is the multi-window interrogation. And you see we can measure the aortic flow from at least 5 windows, or you can have a modified window of your own as well. And you see that the peak velocity is not usually in line with the apical window. Most of the times you have to go with the suprasternal or right suprasternal window. And one study was found that right parasternal window shows most of the times this is the location of the highest peak velocity. You see there are 2 cases here. Apical mean grading was 58, and from the right parasternal, the mean grading was 85. But in this patient, apex showed higher gradient, and the parasternal window does not show a higher gradient. So you have to evaluate every patient from all the 5 windows minimally. Whether you find a peak velocity of 5 either from the apical window, please evaluate from every window. Now, when we are talking about aortic stenosis, there are 3 things which we talk about: aortic valve area, peak and mean gradients, and the DVI. And mean gradient is, as far as I am concerned, is a specific marker, whereas aortic valve area is a sensitive marker. The LV ejection fraction, which was usually considered to be, Dr. Nusrat, can I have your attention, please? Ejection fraction, when normally we consider that if it is less than 55, it is severe. But the recent guidelines say, the American guidelines say that if it is less than 60, one should consider that this is left ventricular failure setting in. European guidelines are still saying 55. These are the various phenotypes depending on the etiology, treatment status, and I would talk about the flow-related phenotypes in detail. And after this slide, I'll talk about that. So there are things when we are describing about the discrepancies in defining the aortic stenosis severity. Now this can be AS velocity more than 4 and valve area more than 1. So one thing is discordant here. Or AS velocity less than 4 and aortic valve area less than 1. Again, one thing is discordant here. In both the situations, we have to check. First thing is the left ventricular outflow tract, whether we have measured it properly, and most importantly, whether we have taken the TVI of at the plane of the annulus or not. We have either gone beyond that or below that. So measure the velocity properly, and how to do that we'll discuss later. And measure the TVI at the same plane. Then compare with the previous echoes. Check the signal from distance. That is the same thing. The most important thing is, as in our part of the word, where the BSA is less than 1.5, especially in females, or in the Japanese population where the BSA is less. So here indexing the area is very, very important. Then you have to see whether here we are dealing with a higher cardiac output state and we measure for AR severity, and here whether mitral valve is involved or not and a low output state is there. So a likely causes when the velocity is high can be high output state, significant AR and larger body size. And with the lower velocity, there can be low output state, severe mitral regurg and smaller body size. So now I will talk about the most important phenotypes, which can be classical low flow, low gradient aortic stenosis, or paradoxical low flow, low gradient stenosis. And then is the normal flow, low gradient with symptoms. So in this kind of situation where there is classical low flow, low gradient, these are patients usually with HFrEF. They have enlarged LV cavity, depressed function, and functional MR with them. And paradoxical ones are usually the patients with HFpEF. They have smaller LV cavity, concentric LVH, and restrictive physiology. Now, how do we deal with them is very important. For classical low flow, debutant stress echo or DSE is very, very helpful because that is going to tell us about the flow reserve. So in these kind of classical low flow, low gradient, probably we are better off doing a DSC. But with paradoxical low flow, low gradient and normal flow, low gradient, calcium score is very helpful. And the cutoff values for male is 2000, for female it is 1200. And if the calcium score goes beyond that, that is a class 1 or 2A indication for AVR. Now, you have seen here that there is a discrepancy in the sexes when we talk about the calcium score. For males, more than 2000, for females, 1200, and it has been found that females generally have more of a fibrotic disease there. The etiology for that is usually the female sex hormone effect and different response to the renin-angiotensin system. That's why females have more fibrotic disease. So more calcification in men. In our patient, the patient I described, her calcium score was more than 2000, about 2100. So we decided that this patient requires surgery, and on detailed inquiry, she turned out to be more symptomatic. So I've talked about that the major area of concern in aortic stenosis is looking for the annulus. And we generally assume in our calculations that this annulus is spherical, whereas truly speaking, this is elliptical. That's why there are errors. And to overcome these errors, as I've been asking Dr. Praveen, there is a hybrid method where we do the LV outflow tract area by CT and do the velocities by Doppler. And when we combine these two by this hybrid method, the general consensus is that cutoff point for severity is 1.2 as compared to the echo severe valve area of 1.0. There's another hybrid method which has been very recently proposed from the Mayo Clinic, and they say that you get the calcium score divided by the mean gradient, and the higher the value, the more riskier the patient is for the surgery or whatever. And our patient has a score of 42, so she was nearly touching 45, which is the cutoff. So we referred her for surgery. Then there's a concept of staging. Valvular heart disease is staged depending on symptoms, valve anatomy, severity of the valve dysfunction, and response of the ventricle and pulmonary circulation. And you see here, patients are staged hierarchically in a given stage or worst stage if at least one of the proposed criteria was met within the stage. And these stage 1 can be where there is LV damage, mass index is more, grade 2 diastolic dysfunction, or strain is slightly less. Stage 2 is when LA mitral damage is there, index area is higher, or atrial fibrillation is there, MR is there. Stage 3 is when there is tricuspid damage, PA pressure is more than 60, moderate to severe TR, and stage 4 is when there is RV damage there as well. So we can stage the patients and pick these patients who are in a higher stage for earlier surgery. Now the question is what to do after we have made the decision, how to proceed with them based on the symptoms, decreased ventricular function, and earlier intervention may be considered depending on the stress test, biomarkers, rapid progression, and presence of very severe stenosis. Now here you can see where patients are at risk or mild to moderate. It's very simple that we follow the patients. If there is severe AS and it's asymptomatic but LV is down or symptomatic, AVR is recommended. Now what do we do with these stage C1 patients where they are severe AS but they are asymptomatic? And I'll tell you how to deal with them. So these are like here, we just observe, and here we are going to refer them for surgery. But this stage C1 is really very, very important. And we refer them for CMR. And if there is, because CMR is going to pick the reactive fibrosis or replacement fibrosis, whether that has set in or not. Because if replacement fibrosis is set in, there's a scar. So these are the patients, they should be picked very, very early, because if the scar is formed, that is even after AVR or TAVR, that is irreversible. So then the quantification of myocardial fibrosis by CMR, generally there is slight discrepancy in males and females. Males have generally a focal replacement fibrosis, whereas females have diffuse interstitial fibrosis. And there's a role of PET setting in where we are looking for activated fibroblasts, picking up these severe patients who are rather asymptomatic for having earlier intervention in them. And there are some other parameters which can help in picking up the patients, because all of them cannot have a CMR or PET. So there are other things which is like a restrictive type of diastolic dysfunction, strain which can be done on the echo, and then a drop in blood pressure when we put them on treadmill. Although it's a very tricky patient, we are very, very careful in putting patients of severe AS on treadmill, but they can be put on that. And if there is a drop in blood pressure, they are the candidates for surgery or intervention. Very severe AR, and then the biomarkers, BNP if it is more than 3 times. But apart from the BNP, people have been advocating the TROP, because if in these asymptomatic patients TROP is negative, that means the myocardial damage is not set in. So in one of the studies, the EVOLVE trial, they have used TROP as like cutoff point where when to send the patient for CMR. Because if the TROP is high, you send the patient for CMR. If the TROP is negative, then you wait and observe those patients. And then there's a rapid progression or drop of ejection fraction. So these are the patients who should be picked up early and treated earlier, because only then we are going to save them. So to conclude, for discordant gradients, smaller valve area and low gradient in a symptomatic patient, we calculate DVI, look for the indexed area, rule out measurement errors, validate stroke volume and aortic valve area by other modalities I have told you. We confirm severity, especially in classical low flow low gradient by DSC, and in paradoxical low flow low gradient and normal flow low gradient by CT, and look for calcification. And we have to remember that in severe aortic stenosis, we have to evaluate both aortic valve and myocardium. Echo is the first line imaging assessment. Biomarkers are very helpful, CT for calcification, and CMR for myocardial fibrosis. Thank you.
Thank you, Dr. Shahbaz. Excellent talk. If there is any question from the audience or maybe from the panelist or any comment?
Sir, small comment. What's the significance of taking an aortic valve area with reference to the body surface area? It's just for the audience. Sir. I know.
Taking, as I've told you, that especially in our part of the world, the body surface area is generally smaller. So we really have to take the indexed area, which gives a good correlation with the symptoms, with the overall severity of the disease, and the prognosis of the patient. So indexing them would tell you when to intervene, and in a smaller body surface area, in a larger body surface area, what is going to be the impact. Like in a very obese patient, an area, if it is not indexed properly, can give you a wrong information. Yes. Similarly, in a smaller body surface area patient.
Thank you very much, sir.
That means we should not, document the actual aortic valve area. We should document
Index.
Actually, we should be documenting both. And more importance should be given to the index area, but we should be documenting both.
So this brings me to another. Sorry.
Yes.
This brings me to another, I would say dilemma. When we have a patient who has got a body surface area of 1.3, 1.4, and aortic valve area of 1, it might not fall in the severe category then.
Yes, certainly.
Yes.
That's why we are indexing it, that we
Sir.
are not going to wrongly send any patient for
surgery.
Intervention, or
Sir.
wrongly sitting on them and not sending them for surgery or intervention.
Sir. Sir.
This is in the guidelines.
Myocardial strain in AS.
Well, that is important because, like as you have seen in all the stages, we are looking for the severity assessment, for the staging. We are looking at the strain at the same time as we are assessing the severity by other echo modalities. Like in stage 1 in the classical, which I have shown you, if the strain is less than 16, they are qualifying class 1A indication for intervention.
Exactly.
So strain should be done right away.
So strain should be done in every case,
Yes.
in AS cases, because
Yes.
the
Because that is how you are
GLS
going
will-
to pick the patients who are still not showing signs of LV failure or symptoms, and their myocardium is down. So you pick them early, send them, because
So if
their myocardium can be
So
saved.
if the EF is above 60% and the GLS is less than 16, so is an indication for the surgery, and the patient is having borderline symptoms.
Yes, in such kind of patients, you at least get at least one more modality. Like one thing you have like supplemental thing which is supporting your point, because otherwise this single thing is telling you that the myocardium is at risk. So just get a support from the other thing as well.
But it's not in this latest guidelines में अभी जो AS वाली जो मैं देख रहा हूँ उसमें अभी एल्गोरिथम के अंदर तो स्ट्रेन का जिक्र नहीं है,
नहीं,
लेकिन
strain
आ
का-
जाएगा
हाँ,
अभी, आ जाएगा. Sir.
जी.
So what about
sir.
contractile reserve? We see before usually, in aortic stenosis severe, we see the contractile reserve via echo. Now we are moving to multiple modalities to see the function like
So,
myocardial fibrosis.
in the low flow, low gradient AS, the classical one, doing dobutamine stress echo is only going to help for looking, number one, whether there is true or pseudo aortic
I'm
stenosis,
asking only
and
for
then
for the low
flow
EF
reserve.
we have to see, or we can see for the normal EF.
No, it's better to look in the low flow, low gradient, not in other cases.
दूसरा आपने जो वो ABCD मेंशन किया है
जी.
इन लोगों के लिए मैं थोड़ा सा बता दूं कि ABCD बेसिकली हार्ट फेलियर की स्टेजेस हैं. A stage is जब predisposing factors are there but there are no actual symptoms. B is when you have a diagnosis, और फिर subsequently C में there are more symptoms and D जो है उसमें severe symptoms. तो बेसिकली हार्ट फेलियर की स्टेजेस हैं, वो इधर भी अप्लाई हो रही हैं
जी, उन्हीं को हमने वैल्व के लिए कर दिया ना, वो मैंने बताया था कि उनको अब वैल्व में भी अप्लाई करना शुरू कर दिया हमने।